He was incarcerated about 9 years ago, and he has several unprofessional tattoos, so he has several different exposures. He has a history of migraines, OA, bipolar, hypertension. He is on Suboxone, and you can see his drugs there. He's not immune to Hep A or Hep B. His blood work, his platelets were okay. His INR was normal. His ALT and AST are elevated. He's genotype 1A. His APRI score was 1.3. His serum fibrosis score was F4. So I ordered a elastography. And the elastography said F0 to F1, and the ultrasound showed normal size and echogenicity. It did have a old hemangioma that's been seen for a few years, so I didn't order an MRI for that. Other than that, we started him on his vaccines. I'm just kind of, where do I go from here? Because of this quarter results, I'm assuming the elastography would be a little bit better than the fibrosis scores. So basically, can I proceed with treatment, or do we need to do some more testing?
Awesome. Thank you so much, Gary. That was a great case presentation. Before we go into any case recommendations and feedback, did anyone have any clarifying questions for Gary about the case? And feel free to unmute or chat in, and I'm happy to read it out loud. All right. And any recommendations from the hub members? Dr. Gilfus, I noticed you unmuted there.
Yeah. Gary, yeah, thanks for presenting them. One quick question, I guess. This is about his BMI. You probably have that on there. Yeah, you do. It's he's actually 184 pounds. Okay, so he's not a very big guy. And the propranolol is being used for anxiety, I'm assuming. This is, whenever you're talking about a liver disease patient, you see propranolol, it always makes you stop and think to make sure they're not using it from a non-selective beta blockade for varices. This is, I'm assuming it's the wrong dose for that, but is he getting it more from a mental health perspective?
It's for his migraines.
Oh, nice. Awesome. Okay, so he's on prophylaxis from that. Okay, cool. So your case is beautiful example of discordant results of your various non-invasive biomarkers and imaging modalities to assess what's going on. So what we're stuck with is, let's go back and think on his case. He probably has not had a really long history of hepatitis C if we think his drug use was only 10 years ago. Obviously, he has a couple of the risk factors, but natural history would probably say, okay, he's likely not cirrhotic, just purely from natural history with 10 years in genotype 1A. And then we get down to his platelet count, which is pretty darn normal looking, which is very comforting. We have a good looking ultrasound, at least in regard to morphology. He doesn't have a classic cirrhotic appearance on liver ultrasound. So everything there is making me say that if you ask me which direction I think this guy's actually in, I think the APRI and the serum biomarkers are actually probably an overestimate of what's going on. I bet you they are representing more than anything his impressive transaminitis. He's got normal INR, normal albumin, normal bilirubin, and all that stuff. So that being said, what do you do in these scenarios? And Dr. Feinberg's I'm going to steal a word that I think I stole from her, I borrowed from her. That's triangulate. You try to use this stuff and triangulate the truth. And I don't know, I think what I would do is approach this guy with treatment and likely optimism that he's not cirrhotic. However, big caveat, you're sort of stuck doing HCC screening, at least for a while. And what I mean by that is I would repeat his fibrosis markers and recalculate his APRI and everything after you've treated him and cured him. And I bet you're going to get much more optimistic results. I genuinely, just to be clear, I genuinely think he does not have cirrhosis from either natural history or liver imaging. However, because you're stuck with this APRI and your serum fibrosis markers, you can't absolutely rule out some degree of scar tissue. And again, it's that scar tissue that's oncogenic. So that's what I would do. It's sort of fudge factor on him. I'd treat him optimistically. He's genotype 1A, so sky's the limit of the drugs you want to pick. His viral load is low, again, so to give credibility to all, or give credence to all of the possible treatment options, he could get Zapatir if he did a genotype 1A polymorphism study. You could give him Harvoni 8 weeks. You could give him Epclusa 12 weeks, or Mavorite for 8 weeks, any of the above. Now I see his Medicaid, so that'll restrict your decision making to the Epclusa or Mavorite. But yeah, that's sort of what I'm thinking on him. I bet you we're just, the biomarkers and APRI are just reflecting his transaminitis, which will improve after a couple weeks of his therapeutics. And by the way, that's awesome. You got an elastography machine. Heck yeah. Way to use it. Does that make sense what I'm saying?
It does.
Okay, good.
I was, from listening to previous everything, it seems like that's what I was kind of thinking, but I just wanted to touch base. 'Cause I know those numbers are off.
That they are as discordant as you can get. An F0 via elastography and an F4 via serum biomarkers. That's as much of a wow as you can have on discordance.
Right. So I will just chime in by saying I think Dr. Gilfus gave a brilliant answer. I think that exactly the situation is that his significant elevated transaminases are what pushed your non-invasive markers. And we do think that the elastography is much more reliable. And I will bet exactly that if you repeat them, you will see them really decrease significantly. But since you've got a F4 in your chart, I think from a medical legal point of view, and just to dot every I and cross every T, it's not a bad idea to do an initial follow-up. But I'm pretty sure that you're going to discover that this gentleman does not have significant fibrosis. That's a great case. Thank you for it.
Thank you.
Thank you, Dr. Feinberg, and thank you, Dr. Gilfus, for the recommendations and feedback. Gary, did you have any other questions about your case that you wanted to go over with the group?
No, I think they were answered.
Awesome, sounds good. And any other hub members or folks from the group here that wanted to comment on the case before we go to the second case? All righty, sounds good. Thank you so much, Gary, for the great case. Really great learning point as well. So we appreciate it very much. Dr. Rood, I'll go ahead and share my screen and pull up your case. So anytime you're ready, I'll just turn things over to you.
All right. So my case is a 49-year-old lady. She is a longtime patient of our clinic. She was diagnosed with hepatitis C in July of last year. She is very adamant that she thinks the way she got it was because she had a partner that had known hepatitis C that cut his wrist and attempted suicide, and she cleaned up the blood. And that happened earlier in 2021. So she believes that's where her diagnosis or where her exposure was. But she does have a history of intranasal opiate and amphetamine use from 2008 to 2021. Her last use was actually in September. She has been in an MAT program since that time and reports doing well. Her only other exposure I come up with was she was incarcerated in 1991. So her other comorbidities that she has type 2 diabetes. She has a pretty interesting cardiac history. So she had Prinzmetal angina with severe spasm of the LAD to the point where she got a CABG done in 2015. And she had a cath done 2 years after that CABG that showed no CAD. And her bypass that she had actually had closed because her vessel unspasmed since then. She has GERD, she has dyshydrotic eczema, asthma, or anxiety and depression. Her medications, she takes amlodipine, metoprolol, aspirin, atorvastatin, she has nitro. She hasn't needed that in a long time though. Suboxone, Wellbutrin, Buspar, Remeron, Metformin, and omeprazole. She is not immune to hepatitis A or B. She weighs 178 pounds. Her labs, her CBC was normal with a platelet count of 265. Her CMP looked okay. Her creatinine was fine. PTNI and R were okay. AST and ALT were elevated at 170 and 240 with a normal alk phos. Her bilirubin was okay. So her APRI was 1.426, that was elevated. Her CTP was class A6. Her serum fibrosis marker was F0. She's genotype 1, and her viral load was 318,000. She's HIV negative, and her vitamin D level is 22, so it was low. So I am replacing her vitamin D. Since she has only been clean since September, I plan to follow up with her in April and wanted to see how she was doing. So that would be about 7 months at that time if she has been doing well. She doesn't follow with our MAT program, so I can't follow her quite as closely, but I wanted to see how she was doing. One of the questions I had about her, I know we kind of talked about it with the last case too, but so her fibrosis marker was F0, but her APR was super high. So I know her AST and ALT were high, so I guess maybe that's why that's discordant in her case. I was going to do an ultrasound. We don't have elastography over here. Is there anything else that I should do for that? And then for her insurance, I was thinking with the Medicaid that Mavorite or Epclusa would probably be the options available.
Thank you so much, Dr. Rood. A great case again, too, so thank you. Any clarifying questions from the group? We did have a question in the chat asking what was her age. I can pull up the case again.
She's 49.
49. Okay, thank you. Any other clarifying questions from the group? All right, and any feedback or recommendations from any of the hub members?
Here, I'll start on this one. So thank you very much, Dr. Rood. You have potential drug interactions with these this patient's baseline meds, regardless of whether you want to go in an Epclusa or a Mavorite direction. So, you know, that's the first thing that you need to sort out is, what can you do about the omeprazole? I think she was on 40 milligrams. Can you decrease the dose? Can you hold it for, the period of treatment? I'm trying to remember the other. Could you put the case up again, Mithra? I don't have all those con meds memorized. But there was a statin and there was, So there was a atorvastatin and the omeprazole. Oh, so she was only on omeprazole 20. All right.
Mm-hmm.
So what you need to do is sort out her statin and her omeprazole dosing and what possible ways can you manipulate these. She is a Medicaid recipient, so the preferred regimens are going to be Mavorite or Epclusa. And so you're going to need to sort that out one way or the other, right? The omeprazole is a problem for Epclusa. The atorvastatin has a interaction with Mavorite. And it's just a matter of, what your comfort level and her willingness to rearrange things is. And I think the other thing that really caught my eyes, I think she has a quite low vitamin D level, right? 22. And you really want to get her immune responsiveness as spiffed up as you can. So this patient's certainly a candidate for prescription strength vitamin D, and especially if you're not going to see her for a little bit, you can get her to a level that's sort of 60 or over, probably by the time you're ready to start medication in her. And that helps improve the response, I think, to have her immune system really tuned up. And the last thing is, you know, if, would you scroll up again, Mithra, please, to her other diagnoses? So, you know, it is certainly possible that her anxiety, her depression, her type 2 diabetes are possible expressions of extrahepatic disease. And it would be important to monitor those conditions, you know, as she is treated and clears her Hep C. Her diabetes may improve. Her anxiety and depression may improve. I mean, sometimes the extrahepatic things improve. Sometimes they actually go away. Depends on how lucky she is. But these might be situations that, you know, really benefit from curing her Hep C and may enable you to, you know, further decrease some of her other con meds, you know, and kind of give her a more contained set of medicines that she has to take every day. And I would love to hear what my colleague, Dr. Gilfus, has to say.
Oh yeah, Dr. Feinberg, that was a beautiful comment about the extrahepatic stuff. Yeah, and well said. And I'm glad Rachel Mitchell's on too, because I can never remember is there a dosage limit or something with Lipitor? Rachel talk about that in a second. But the only thing I wanted to mention is, just like the last case, this discordance between the APRI and between the non-invasive biomarkers. So here you have an elevated APRI and a normal fiber short. And I'm going to give different advice in this one. I'm going to say you probably don't need to do HCC screening long term. You know, the last case made me a little more worried, even though I don't think he's cirrhotic. It's harder to ignore harder to ignore a FibroSure than an APRI. You know, the APRI can be, it has two factors. It has literally just the AST and the platelets, and it is therefore the most susceptible to an aberrant lab result, one particular lab result. Whereas the FibroSure has 6 tests in them, and I have to read these because I don't remember them. It's you know, the transaminase that it looks at is ALT. Then it has alpha-2 macroglobulin, haptoglobin, alpha lipoprotein 1A, bilirubin, and gamma, the good old gamma glutamethyltransferase. You know that one. I'm kidding, of course. But anyway, these are all biosynthetic components. So in this scenario, you know, you're more reliable of the markers is actually saying there's no advanced fibrosis. I do think that just to make everybody feel better, liver ultrasound passes the logic test, and I bet it's going to look great. And just like in the last one, after treatment, recalculate your APRI, which would again be your only pessimistic predictor in this scenario. And I guarantee it's going to be normal, straight up normal.
And this is Rachel. I can speak to the drug interactions here on a question I just noticed. So with the atorvastatin, going to be a little sticky just because it is contraindicated with the atorvastatin, or the Mavyret and atorvastatin. They're contraindicated. It doesn't really matter the dose for those two. Any of those doses, they recommend to avoid the atorvastatin. So got a couple options. I know you mentioned her tricky cardiovascular history here, so she could hold it for the 8 weeks that she's on Mavyret, or you could change it to another agent that maybe has less likelihood of interaction there with those ones. You could do like a max of 10 milligrams with rosuvastatin, which is Crestor, or maybe try like a fluvastatin or another one of those agents. If you do go with instead, if you try to avoid that one, you want to keep her on that atorvastatin and go with the Epclusa version. There is one of those, which I love, the generic just monitor with the atorvastatin and the Epclusa, so she knows signs and symptoms of the myalgias and things where she may need to come off of it or have a lower dose. So there's no, prior to therapy change to the atorvastatin necessarily at this dose. She can stay on it, but if she starts to have symptoms, maybe stopping it or lowering that dose. And then the omeprazole, that dose is good for 20 milligrams if she absolutely cannot go off of that. Just remember with Epclusa, The recommendation is if she could come off the PPI, that's best. But if it's medically necessary and she can't come off of it, that 20 milligram dose is actually okay. She's just going to have to work around it with the administration. The recommended administration for those two is for her to take the Epclusa with food and then take that omeprazole 4 hours later. So I usually like to get a schedule with them if they're going to take their, depending on what time of day they normally have food like breakfast or lunch, and then give them that schedule. So if they say, I'm going to eat lunch at noon and I'm going to take my Epclusa with that, so I have food on my stomach, then at 4 o'clock, I'm going to take my omeprazole, just because sometimes people get a little confused with 4 hours versus at least 4 hours. So as far as those kinetic studies were done, the best option is to stick to that 4-hour window if you can and do it at 4 hours. And then the only other question I have here, because you're going to need it for Medicaid, and I wasn't sure if I saw it on here. I think you mentioned that she's not vaccinated, or maybe it's not immune to hepatitis B, but I don't think I saw her serologies to know whether or not she had like the isolated core positivity or anything, but those will need to be submitted for West Virginia Medicaid.
Thank you all so much for the recommendations. Dr. Rood, I noticed your image is a little frozen. I'm not sure if we lost you here. Let's see, we may have lost Dr. Rood due to connection issues, but let's see. Dr. Rood, I noticed you had kind of hopped off with the connection. Were you able to hear that okay?
Yes, I was. Sorry
Awesome.
for a second.
No worries at all, no worries. Thank you all so much for the recommendations and feedback. Dr. Rood, did you have any other questions about your case that you wanted to have addressed?
Nope, everything was answered. Thank you so much.
Awesome, thank you so much. All right, so Jenna and Robin, I see you both are on from Tug River. We did have a case submitted by Alice. She's not on here, so I wasn't sure if maybe you guys were gonna present the case today. If not, no worries. We can absolutely reschedule to another date. I just wanted to ask you all.
It's actually my patient. Alice she's just a navigator, and so I'll go ahead and present that today if it's okay.
Perfect, sounds good. So I'll turn things over to you then. Thank you.
Okay, so this patient is a 27-year-old male. He started using drugs at the age of 13. They were introduced by some friends that he had, and then he started using IV drugs around the age of 18 or 19. As of the 16th of next month, he will be clean for 1 year. So he's doing very good right now. He's living at a fellowship home in Mercer County. He has a good support system. So I think he's going to do very good with treatment. So his labs, well, his medications, I'll start with his comorbidities. Anxiety, depression, and hypertension. His hypertension is mostly controlled. I just increased his propranolol actually today, which is not usually my first choice for hypertension control, but he came to me on it, so I just continued it. I don't see any significant interactions that he'd have with any of the medicines that he could have. He's on the pantoprazole. His hepatitis status is he's immune to both hepatitis A and B. His core was negative on the hepatitis B. His BMI is 35.7. His CBC is mostly okay. Creatinine 1.16. Platelets were 231. His liver enzymes is ALT 112 and his AST 42. His APRI score 0.445. And then child Charcot-Pugh was class A, the score of 5, and his MELD score was only 8. So I don't think he has any cirrhosis. Vitamin D, of course, was low, so we're supplementing that. He is a genotype 3. His viral load was 1,030,000. I think for him, it's relatively a simple case. I don't think he has any kind of long-term liver damage as of yet. So I think Mavorite for 8 weeks would be adequate for him, if that's what everybody else agrees with.
Thank you so much, Robin. Great case presentation. Did the group have any questions for Robin in the case? And any feedback, recommendations, comments from the hub members? Dr. Gilfus, I
Hey,
noticed
Robin.
you
Yeah, great presentation. I love how when you present the immunity to Hep B that you automatically go and tell us about the core. I love that your brain goes there. So perfect thinking. You're right. I can't make this case complicated at all, which is good. You know, you're limited to your pan-genotypic agents. So really your Mavorite or Epclusa, and the Mavorite does look like the simpler option in this scenario. Remember, we do not, even though it's a genotype 3, we don't need any pre-treatment polymorphism studies because they're not cirrhotic. So if this was a cirrhotic patient, you would need to do some polymorphism studies if you're going to use Epclusa. But really in this scenario, yeah, I agree with you. Mavorite, and then cure this fellow. You know, the most mind-blowing thing about this guy's presentation was he has a 20-year smoking history almost at age 27. I mean, I was just sitting there thinking to myself, it's pretty amazing. I have kids that age and I'm glad they're not smoking yet. So rough life. He's obviously had a lot of challenging influences in his life to lead him to tobacco by age 9. So anyway, you'd be doing him a good favor, help his anxiety like Dr. Feinberg mentioned. You may improve that and go from there.
Thank you, Dr. Gilfus. And Dr. Feinberg, I saw you unmuted as well. Was there something you wanted to comment on?
No, my only comment was going to be, you know, just what Dr. Gilfus said, which is Mavorite's the easy choice. He's on pantoprazole. And so, you know, if you choose Mavorite, you don't have to worry about the PPI issue and dosing and with food and 4 hours and et cetera, et cetera. So I think that makes perfect sense.
Wonderful. Thank you so much. Any other hub members with comments, feedback, or anyone from the group? Right. And Robin, did you have any other questions about your case before we move to the didactic portion for today?
No, thank you. I think that's good.
Awesome. Thank you. Well, thank you to all the wonderful case presenters today. They were all really great case presentations, so we appreciate all of you. Angie, I'll turn things over to you now for the didactic. I'm happy to pull it up on my end, but if you'd rather do it on your end, I can give you that capability as well.
It's up to you, whatever you prefer. I can probably bring it up, I think.
Okay, sure. Let me make you co-host so you can do that. All right, you should be able to do that now. So I'll turn things over to you. Thank you.
Okay. Can everybody see my screen?
Yes, we can.
All right. Okay, so the new updates for PrEP came out in December of 2021. So that's what we're going to talk about here today. So PrEP was first approved in 2012. New HIV infections after it was approved fell 8% from 2015 to 2019. So these were good changes that we saw. The first oral PrEP that came out was the tenofovir, disoproxil fumarate, and emtricitabine, so the brand name Truvada. The decrease in HIV infections was attributed both to growth in PrEP use and also to PrEP itself, and then also to increased testing, because there was a big move for increased testing around that time as well. And there are barriers to adherence for PrEP. A lot of them, most notably, is going to be substance use and homelessness. Depression is also a factor, and efforts to conceal medication due to stigma, because there is still a stigma with HIV, as we all know. PrEP is part of the federal Ending HIV Epidemic in the U.S. initiative. So I have a graph on this screen. This initiative, the goal of this initiative was to have 50% of people who are eligible for PrEP be using it by year 2030. And at this point, we're falling short. So as of 2020, 25% of people eligible for PrEP were prescribed it. According to the CDC, 1.2 million people eligible were the quantity of people that were assumed to be on it. This is actually better, though, than 2015, which showed only 3% of people eligible were prescribed PrEP. So we're getting the word out, we're getting more people on PrEP, and the costs are coming down with the generic medication coming out. So those are all good things. But even with the increases in PrEP usage, some groups lack access to care. And it seems to disproportionately affect certain groups of people. So according to the CDC, only 9% of African Americans eligible for PrEP were prescribed it, while 16% of Hispanic and Latino patients were prescribed PrEP. And compared to 66% of white patients prescribed PrEP, we're seeing a trend that's showing that coverage remains uneven across the groups who represent a majority of the people for whom PrEP is recommended. So that's something to consider as well. So it's concerning to have the lowest rate of usage in those groups compared to others. And also of note, but not represented on this slide, are the additional groups of people who have low numbers of PrEP usage, which includes younger patients aged 16 to 24, transgender women, and residents of southern states in the US. And we know that HIV numbers tend to be a little bit higher in that geographic area. So of the updates that were published, there are some that we'll go over today. So they include cabotegravir IM as a new option for PrEP, which was pretty exciting because it's our first injectable option for PrEP. They're now recommending to inform all sexually active adults and adolescents about PrEP. There are new studies out that show that a lot of new HIV cases occur in men who have sex with men who actually don't meet the criteria for high risk. So the recommendations are changing a little bit to not just recommending that our high-risk population use PrEP, but offering it to everybody who could be at risk. There's also better charts identifying indications for PrEP, and I'll include in my last slide the link to these guidelines in full. Creatinine clearance recommendations have changed a little bit. So the creatinine clearance is an assessment of renal function, and they're now recommending it be checked every 12 months for patients who are younger than 50 years of age or who have creatinine clearance greater than 90 milliliters per minute at the PrEP initiation appointment. This is a change from it previously being recommended to be monitored every 6 months in that patient population. For all the other patients, patients over 50 years of age or with renal impairment, it's recommended to be every 6 months. They've also added sections for drug interactions for tenofovir alafenamide. This is not really new drug interactions, but they're just adding it to the guidelines. The most notable ones were St. John's wort, rifampin, rifabutin, and rifapentine. They also added a section to discuss initiation of PrEP and follow-up by telehealth or Teleprep. They added procedures for providing PrEP medication to patients on same day as initial eval. So that's called SameDay Prep. And then they also add a section to discuss 211 Prep, which is the OnDemand Prep option. The new option for PrEP extended release cabotegravir. So this is exciting. Every 2-month injection after the initiation doses. Brand name for this is Apretude, and it is our first long-acting injectable PrEP option. So this is going to have to be administered by a clinician in a clinical setting, and it's administered in the gluteal muscle. Something to note is that at this time, it's not recommended to do this injection at any other site because the pharmacokinetics haven't been studied, so they're not entirely sure about drug absorption at the other injection sites. So it's recommended to stick to that one site. You can start with the injectable cabotegravir, or as an option, you can lead in with oral cabotegravir for 4 weeks. But that is optional. And one thing to note about that option is that oral cabotegravir tablets are not really available at the local pharmacy. You have to get those through ViiV Healthcare. So it has to be something that's planned and obtained through them. The indication is for sexual acquisition of HIV. And this is for adults and adolescents weighing at least 77 pounds And I reached out to the American Academy of HIV Medicine. They have a pool of prescribers just to ask them about this use in IV drug use populations, because the indication does not cover that. And I wanted to see, are providers going outside of these indications? And the general consensus was no, not at this time. So definitely looking forward to some more data on that, because I think a lot of our homeless population will have that coexisting substance use disorder, and this will be really a good option for them. This is also a good option for patients with poor creatinine clearance. So creatinine clearance below 30 milliliters per minute, because other oral PrEP options might not be recommended for that group. So this would be an option for them. This would also be a good option for patients at risk for noncompliance. And anybody who just prefers an oral or prefers an injection to oral every 2 months, this would be good for them as well. There is a black box warning with it. You want to make sure that a patient is HIV negative before starting this. And they say immediately prior. The definition for per labeling seems to be within 7 days. So if it's exceeding that, it's going outside of guidelines. The concern there is that if the patient acquires HIV within the time frame, then if they have HIV, this regimen would be subtherapeutic for treating the HIV. It's good for preventing it, preventing the acquisition, but not for treating it. So that's why they want to make sure that the patients are HIV negative before starting. One other thing to note with the injectable as opposed to oral, the guidelines recommend for PrEP in general for testing, for HIV testing for every 3 months. Since this is injected every 2 months, that would just be slightly different. So you would have every 2 months instead of every 3 months for these patients. So the initiation dose that they will start before every 2 months is 2 injections administered 1 month apart. They do have a little bit of a window. So if they can't make it in on their appointment day, they can come in 7 days before or up to 7 days after. If they have a window where they just know they're not going to make that 14-day window, for instance, if they're traveling or they just know that they'll not be able to get there, they can do oral daily cabotegravir. They can do that, and again, it's got to sort of be planned because you have to get it from ViiV Healthcare, but you can do that. They do recommend not doing it for over 2 months, though. So if they're, overseas or traveling for a long period of time, it's important to know that they shouldn't do that for over 2 months. One question that's popular with PrEP also is how long after they start on PrEP will it take to the time where they will have optimal protection against HIV acquisition. For this option, the data is not quite back yet, so that at this time is an unknown for this option. Some counseling points that are important to go over with patients. So injection site reactions can happen. You can have pain, tenderness, induration. They were most frequently noted after the first 2 or 3 injections and then tended to wane after that. But if they do experience that, they can do warm compresses or heating pads. They can take some Tylenol or any OTC pain reliever within a few hours of their appointment or soon after, and they can continue it for a couple of days if they notice that it's something that's bothering them. But it's generally reported to be mild or moderate. So there's also the importance of keeping the subsequent appointments because they do have to make sure that they come in every 2 months. So that's a really important counseling point to go over with these patients. And also educating them about the tail phase of this medication and the risks associated if they're discontinuing the use of this. And I'll talk about that in the next slide. So when you take the cabotegravir, if you decide to discontinue it, upon discontinuation, the levels go down, of course, over a couple of months. So during they call this the tail phase. During this tail phase, the drug levels aren't enough to prevent the HIV acquisition. So that's counseling point number 1, that you want to make sure that they're aware of that they need to use other methods or a different PrEP option. And then your other issue is that while they're at these subtherapeutic levels, those levels might still be sufficient to select for viral strains that are resistant to not only cabotegravir, but other medications in this class. And it's a popular class, so it's kind of a big deal to make sure that the patients aren't resistant to it. So that's something to consider with the cabotegravir. So teleprep's becoming more and more common. So we've got a lot of technology in healthcare now due to the COVID-19 pandemic, due to people's busy schedules, and a lot of people are looking to technology to replace in-person clinics. So the guidelines came out to recommend some guidance for prescribers for teleprep. So in this section, they want to make sure also that teleprep is available as an option because we want to get prepped as many people as we can. So despite their rural places that they might live, despite like weather constraints or busyness of their lifestyle, we want to make sure that we get prepped to as many people as we can, and telehealth does assist with that. So services that you can provide via telehealth, you can use the phone or the computer, and you can do video chats, phone calls, or text messaging. You would do screening of the patients on these calls, initiation of prep, follow-up visits, ongoing risk reduction counseling and support services. Linkage to care is important for clean needles, sexually transmitted infections, and or if they test positive, HIV specialists as well. For lab requirements, there are lab kits that you can order, and they would be sent to the patient, and then they get sent in, and the provider gets the results. So those are an option for patients who absolutely don't have access to a lab. For most patients who probably do have access to a lab, you can always give them orders to go to their local hospital or maybe a lab core, depending upon what you're getting the lab for. And they can get those results a little bit more easily, especially if they're an hour or two away from their main HIV clinic or the main clinic where they're seeing the practitioner prescribing the prep. There are home kits that are FDA approved, and those are recommended in the guidelines. And then as a very last resort, there are oral swabs for patients for HIV testing. And this is only for someone who has no possible access to a lab and can't bring themselves to do a finger stick at home. These are really not recommended, but better than nothing is kind of the recommendation. So those can be used. And typically the recommendation in the guidelines will say to have the patient take a picture of the result that they get and send it to the provider as opposed to interpreting it themselves. And also another option you can offer for patients are 90-day medication supplies. So instead of 30 days, like if they have transportation issues, which a lot of people do, you can give them 90-day prescriptions, and that way they don't have to keep running back and forth to the pharmacy. And you just would make sure that they can get back to the clinic or at least get you some sort of HIV negative test at that 90-day mark to continue. Off-label, on-demand 2-1-1 dosing for PrEP. So this is called intermittent or event-driven or on-demand PrEP. It's got a couple of names. It is an off-label. It's not FDA indicated to be used like this, but there are a lot of studies that back it. And the guidelines do address it, so we'll address it today. So this option is for men who have sex with men, or at least that was what the study covered, who are having infrequent sex, which is categorized as less than once per week. So they would take 2 pills in 2 to 24 hours before the sexual event, and closer to 24 hours is preferred, but they need to be able to anticipate the event or at least delay it by at least 2 hours. And then they do 1 pill 24 hours after the initial 2 dose, and then 1 48 hours after that. The recommendation is to prescribe no more than 30 pills without follow-up and documentation of another HIV negative test. The thought process behind that is that if the patient is having sex less than 1 per week, they'll have enough medication to cover up to 7 intermittent sexual events. They recommend that it not be used in patients with active hepatitis B infection. And the instructions for additional doses if they find that they're needing it more in the days to come. If sex occurs on the consecutive day after completing the regimen, they can take 1 pill per day until 48 hours after the last event. If they have a little bit of a gap, but it's less than 7 days, they can take the 1 pill a day regimen. If the gap is greater than 7 days, and they just have to start all over with the 2-1-1. The danger with the Hep B, just to go back to that, is because it could cause flares if you episodically use that medication. Next, we'll talk about same-day prep. So this is where the patient comes in for initial consult and you prescribe them prep right there, as opposed to having them come back after you get more lab results. So a reason to consider this would be if the patient's at high risk of acquisition before follow-up. So if they've got some really risky behaviors and you think that there's a potential that is real enough that they could acquire before the follow-up visit, you can go ahead and do same-day prep prescribing. If they have scheduling issues and they just know that they're not likely to make it back for an appointment in a week, you might consider that. Or if you're just unsure if the patient will return, this would be a good option. The requirements to do this, though, you do have to check some boxes before this can be an option. You have to confirm the HIV negative status. So this is always a must no matter what if you're prescribing PrEP. You ideally want to do it with an antigen antibody lab-based testing. You want to test their renal function because that makes a difference with what medication you're going to prescribe. So test the renal function, the creatinine clearance. And you want to counsel on safe practices, safe needle practices, or safe sex practices. Importance of compliance is really important for these medications. Frequencies of following up going forward. So you have to make sure that they're aware they do have to come back every 3 months or send you a negative test result. And just let them know what the side effects of the medication are is always a good idea. So the optional testing that you can do STI testing. And there are some options if you've got a patient that doesn't like to go to the lab or come to clinic. If you need to do the STI testing, there are some kits that they sell, and some are referenced in the guidelines. I had my student Trey looking up some of those tests, so we couldn't confirm their FDA approval for the STD test. We did confirm it with a couple of HIV negative tests that they recommend, but those ones claim that they have FDA approval. We couldn't verify it though, but there are options out there if that's of interest to you. And referral to substance use disorder counseling, or MAT, if that applies. According to guidelines, you want to avoid same-day prep for the following patients. So if they're not real sure if they're ready to start prep, maybe they need some more time to just consider what their commitment is to the whole process and the medications and to the follow-up appointments. If they cannot complete the laboratory testing for initiation for whatever reason, if they could potentially have HIV infection, either due to a potential recent exposure or if they have signs and symptoms, you'd want to hold off until you further evaluate that and maybe give them some time. For patients who have no means to pay for prescribed medication, there are programs out there, and we'll talk about those in one of the other slides. But you want to make sure you get them connected with patients' assistance programs or connect with their health insurance to see what PrEP option they will cover, especially if you're considering an injectable PrEP. And patients with no confirmed means of contact, that's just a little hard because if they come up HIV positive throughout the process and need to immediately stop their PrEP and you can't get a hold of them, that's a big problem. Or if their renal dysfunction would come back unexpectedly, you'd want a means to get a hold of them. So if they have no confirmed means of contact and you're sure that they're not going to come back for follow-up, that's a problem as well. So for coverage of PrEP, in July of 2021, the Department of Health and Human Services published guidance that some oral PrEP options and their generic versions should be covered by most commercial insurances and some Medicaid programs, along with the necessary laboratory tests and clinic visits. Not everyone's in complete compliance with this, just on the little research that I did, but a lot of them are. So it's at least a step in the right direction. Ready Set Prep is another option. So this is a program for uninsured patients, and this is available if you have a valid prescription, if you have a negative HIV test, and you can enroll given that phone number and also that website. Does anybody have any questions? Those are the links there. When Elizabeth or Misra send out the notes, those citations will be in the slides.
Absolutely. Thank you so much, Angie. That was a great overview and coverage of those updates. So we really appreciate that. And absolutely, we'll be attaching it in the recap email so everyone will have a copy of those citations there. Did anyone have any questions or comments for Angie?
Oh, yeah, thanks a lot, Angie. The fact that we've been awaiting these updated guidelines since 2017. CDC kept saying they're coming, they're coming, they're coming. So it's great that they're finally out, and it was terrific that you covered that. Just a couple of comments, and actually, because I have a long history with HIV and PrEP, I actually chaired the FDA approval meeting that wound up approving PrEP in 2012. And it was a very contentious meeting. There were actually a lot of people who were opposed to this. And the meeting went on for 12 hours, which was a whole nother thing in itself. Part of the reason that early uptake was so slow was not only because it was new and a lot of providers didn't know about it, but it was extraordinarily expensive. There were no generics. The patient assistance plans were very not generous, and it was really hard to actually just get medicine for people. Just a few comments about cabotegravir. A very good reason that this injection is given in the gluteal muscle is because it's a 3 ml injection. So even if the pharmacokinetics were good from the deltoid muscle, I don't think you'd be wanting to put 3 mLs in an arm. So that's an issue. And then just to be aware from an administration point of view, not only does it have to be given by somebody who's skilled enough at giving large volume intramuscular injections, but the boxes that they come in are bulky and they must be refrigerated. So it's really important to, if you're at an FQHC that has your own pharmacy, for example, it's really important to find out that they've got refrigeration space for the way the cabotegravir comes packaged. And really, thank you, Angie. That was a really nice update.
Hey, Angie, this is Kaylee. Thank you so much. You did such a great job. And I want to know if Medicaid is going to cover Cabo.
For PrEP. So
do we
they've
know?
got it
Yeah,
on the
do we know?
formulary.
Yeah, I know
Yeah,
for HIV, but I guess, yeah, for PrEP, that's a better question to ask.
Yeah, so they're going to cover it, but it's going to be restricted. So they'll need reason beyond compliance and convenience to use it. So I think they're looking for like homelessness and things of that nature as a reason to cover. But it is on formulary.
Yes, good. Okay, thank you so much. And I just wanted to make just a few points because I spoke with the ViV rep last week, and so he just kind of clarified a couple of things for me too with the Cabo. So just for everybody's knowledge too. So this one for PrEP, it actually doesn't have to have cold storage. So for HIV, that formulation would because of the rilpivirine, but he said that this one doesn't. So it still comes in a bulky box, but you don't have to worry about that piece. And then what else? There was one other thing I wanted to mention about the Cabo, but it lost me for just now. So I'm so glad that we're getting this, but it is going to take some logistics. So if anybody's interested in, using this in their clinic, the rep for ViV, they have like a whole assistance kind of with getting this started and teaching how to administer it and kind of a whole structure set up. So they can definitely facilitate that. I know the other thing I wanted to mention was with the new PrEP guidance too, for ongoing monitoring of HIV status, they actually added this piece in, or at least I didn't know if it was on the old guidance, that when you're monitoring someone that's on PrEP, we need to be doing HIV antigen antibody screening and the HIV viral load. Which was new to me. So just kind of, that's the ideal testing that algorithm that they want you to follow too.
Thank you so much, Kaylee. We missed you, and it's great to have you back for today. But thank you.
I tried so hard to get on. I was like, I've got to get on because I want to hear Angie talk, and I miss you guys. So I was scrambling to try to get out of clinic in time. So I only got to hear the last couple minutes, but I'm so happy to see you guys.
We appreciate that. Thank you so much for the comments in addition to that. Any other comments, questions from the group? Alrighty, well, thank you so much, Angie. That was a really wonderful didactic, and I'll be really happy to attach in the recap so everyone has a copy of it and they can review it as well on their end. So if there are no further questions or comments, I'll just go into the announcement. So the February 24th session is actually canceled. The ECHO team is doing their first Super Hub immersion training fully on our own. So we're really excited about that. And it's actually taking place that Thursday and Friday. So we won't be having the February 24th session. So the next time we'll meet is on March 10th, and Dr. Gilfus will be discussing hepatitis B. So we'll see you all in the springtime. I hope it's a little warmer by then, but we'll see you all at that time. Thank you all so much. Take care.